Thank you so much.
Thank you very much, Dr. Gabriel. Does anybody like to has any point for discussion?
Any question for Dr.
Any
Gabriel?
question? Dr. Said.
Let us start, Dr. Said.
Thank you for your excellent presentation. One question for you, what about the landing zone between the subclavian and the carotid? Usually we don't have that big length, so do you have a specific criteria to do instant fenestration or not based on that landing zone?
Yes, it is a very important question. You know, proximal landing zone matters. And what it is request to make the fenestration is at least 10 millimeters. That's enough.
10 millimeters, that means one cell of the stent.
Yes, you need to have 10 millimeters of graft to be punctured. So ideally, you need to have 10 millimeters of graft behind the most posterior aspect of the left common carotid artery to the origin of the left subclavian artery. That's enough.
Okay. Another question, because you know there is a lot of variants of the subclavian artery. If we have a vertebral artery that's coming up normally from the aorta, and which length in the subclavian you put the covered stent till the internal vertebral artery, or you cover the vertebral artery and the internal mammary, or just you land before them?
No, always before the landing zone. Our policy is to preserve the left vertebral artery, for sure, no doubt on that. If you are questioning the problem or an aberrant left subclavian artery coming directly from the arch, then I've seen recently a very intriguing technique from a physician from Brazil. They opted for a combination of fenestration of the left subclavian artery and a chimney, a parallel graft of the left vertebral coming from the right side, but it is quite demanding and in my mind too much.
Usually in such cases we assess the other vertebral artery and the circle of Willis if there is collateral, so we can cover it safely, but sometimes we had some strokes in such patients.
Perfectly agree, but you have to take into consideration that sometimes the left vertebral come directly inside the pica artery, so you have to transpose that. That is our experience. We have always transposed the aberrant left vertebral artery when coming directly from the arch. So never trust solely on the contralateral right hemisphere.
Okay, thank you.
Yeah, I have another question, please, regarding the durability of the technique you did. The durability of the technique. When you use a laser, the excimer laser penetration, you have a direct contact to your graft, and you have a hole about 2.3 millimeter, and then you balloon this. When you the needle balloon, you just have a small hole and a very huge force of the balloon to disrupt this hole. So what do you think about the durability of this?
Probably I was too fast, but there is a cornerstone, a very important paper coming from bench tests that has demonstrated clearly how a gentle progressive inflation of the balloons does not ruin the graft of this new generation device that has a double layer EPTFE that adapt very well in comparison with our other type of grafts, namely the Dacron. So indeed, I guess we do not be afraid of such disruption, either longitudinal or some fabric tears, etc. These are coming from bench tests, from microscope evaluation. This is very important. And so far, it is very preliminary, but we have not indeed also when we have talked with other Chinese guys that have developed this type of technology, no type 1 related or type 3 or porosity correlated endoleak due to the inflation balloon. But once again, techniques matters. You have to do not very aggressive and single shot ballooning to stretch the graft. You have to go very smooth and progressive. And there are some ticks and trips to do the progressive balloon dilatation over, for example, through and through technique to make the balloon more stable and more focal. Indeed, this seems at least not to be a problem right now.
Last question.
Dr. Gabriel,
Last
can I
question.
ask small questions? Very small questions.
Last question by Dr. Said Al.
Dr. Gabriel, it's a great presentation, but I just missed the rate of stroke. You mentioned in the first paper. What was the rate again?
The
Of the
rate
stroke?
regarding site of anesthesia, it depends of the technique.
No, you present a rate of stroke of 3%, did you?
No.
In the rate of stroke,
if I-
it was 3%?
In which table?
In the first table,
May you?
No, that's okay. So my question to you about the stroke rate, okay, 3% is reasonable actually, but is all carotid territory, or do you have any vertebral? Because providing that you remember the fact that only one of the carotid, or only one of the vertebral is dominant, it's usually the left side is dominant, and the right side is not very dominant. So did you have any vertebral artery stroke related to the?
Probably yes, at least in the very first phase of our TIVR experience when we used, but it was in the very first phase, 2001, 2002, 2003, when we had to cover directly the subclavian, disgruntled the left vertebral artery. So probably we had a posterior stroke in my mind. But right now, respecting the anatomy and the left subclavian and left vertebral, we have no more. We have had no more strokes.
And most of the stroke reversible, or any
No,
of them
no, no.
became fatal?
No, when it happened, it was a major and devastating stroke,
thank you.
especially the posterior one, And that's the reason why you have to, we are very careful in the evaluation of the aortic arch. An aberrant live vertebral artery is 3%, has a 3% incidence in aortic arch disease. It is not so infrequent, and you have to respect that, especially when it goes directly into the posterior vascularization.
Yeah, so I have a comment. My name is Hussam Said. I work in Norfolk, Virginia, and we have a big experience with retrograde in situ fenestration of the aortic arch using laser, and it is in a Dacron. We cannot use laser for PTFE because it doesn't work. And we have some of the cases are over 10 years, and we do not have any problem at that junction, which we were always, afraid of what would be the durability of the technique. But actually, durability was never an issue in those cases.
So did you cooperate with Jean Panetton, probably?
What's that?
Jean Panetton, the
With John
surgeon?
Panetton,
Okay.
yeah, it's the same group.
Excellent. Great.
Congratulations, very nice presentation. Tell me, just short question, do you have a preferred bridging stent graft which you use for that purpose?
Yes, for sure, but because we are trying to standardize the protocol of the registries-based data collection, we have opted to go for a chrome-cobalt double-layer EPTFE stent graft, balloon expander, namely the B graft, just to optimize and exploit the fact that it is PTFE on EPTFE graft, just because of that. But there are some other experience using different. Right now, we have decided to go straight forward for this type of combination, but it is an open question, starting from the thoracoabdominal down up to the arch for sure.
Thank you very much.
And now, Zul, I have the honor to present you the second part of this presentation,
Right here.
moderated by Professor Nasser Said, who is the president of this wonderful Congress. Professor Nasser.
Thank you, Professor Rafat. Actually, I just would like to explain something. I have number of cases, 8 cases.